Hey, it's nice to be back talking about stroke again, so welcome everyone. And I am Jamie Elliott, one of the vascular neurologists at UW-Madison, and just talking about some review and updates about stroke care in the pre-hospital setting. So I'm just going to have a brief stroke review about kind of some typical presentations, and then 3 cases that point out some relevant information, and these are patients that we've treated in the past year since our last talk. And then a brief review of some kind of up-and-coming differences in treatment that may affect the pre-hospital setting, and then briefly just some information about stroke access to care. So, as part of our review, stroke is acute neurological injury that's due to loss of blood flow if it's an ischemic stroke, or bleeding if it's a hemorrhagic stroke. And this results in disability based on the area of the brain that's involved. So there's a number of different presentations depending on what brain structures are involved in the process, which we'll go through in a second. It is the leading cause of disability in the United States, and the treatment of stroke is very effective at reducing both the amount of disability and death from stroke. So it's really important to recognize them early, get them to where they can be treated so that they can receive treatment which is effective. And I have on the sidebar here just some information about how frequent stroke is, and that many people with stroke present via EMS. So in terms of signs of stroke, they're generally acute onset, which means that they have no preceding symptoms and start abruptly. Most ischemic strokes are what we call maximal at onset. So that means that they start with severe symptoms out of the blue, and they consist of focal neurological deficits. So those deficits I have outlined here. So you can have language dysfunction, which means that you have trouble getting your words out despite thinking clearly, which is aphasia, or you can have trouble understanding people speaking to you. If you have weakness on one side of the body, that's a hemiparesis, that's a focal deficit. That can sometimes be weakness of the entire side of the body or just one part. So you can have just hand weakness as a sign of stroke. Sensory changes, so that's also usually hemibody, loss of sensation or numbness. You can have loss of vision, so we're concerned about vision loss in just one eye, which would be due to carotid disease, or loss of vision in each eye on one side of the body, which is due to occipital lobe disease. Or you can have double vision. And then finally, you can have a profound vertigo, nausea and vomiting, or unsteady gait. When we think about a hemorrhage, we also include symptoms like an intense or thunderclap headache, the worst headache of your life, and then things like a rapid decline in their symptoms to obtundation or coma. In terms of ischemic stroke, there are some recognizable patterns of symptoms. So we have dominant hemisphere anterior circulation strokes, and then non-dominant hemisphere strokes, cerebellar strokes, and brainstem strokes, which we'll go through each of these. Then we have transient ischemic attacks. So these are the same symptoms as stroke, but your body was able to fix the problem before you have permanent brain injury. And so definitionally, they're symptoms that resolve within 24 hours. The point of this is that it's just as potentially dangerous as stroke, and they have a very high rate of having recurrent stroke symptoms. So patients that are reporting stroke symptoms to you that are back to baseline still need to be evaluated in the emergency department that day. And then hemorrhagic stroke, like we talked about. So a dominant hemisphere stroke for most right-handed people, this would be a left brain stroke. People have their language in their left brain generally, which means that they present with aphasia, right-sided weakness, right-sided vision loss, right-sided sensory loss, and leftward gaze. And this picture is just showing a very large stroke in this area. And so can we see my cursor? Great. So the outlined area is the middle cerebral artery territory on the left, and you can see how it's just grayed out. So that is from the early cell death from a recent stroke. And the normal side is this right side of the brain here. So the pattern to look for, basically if you ever hear anyone complain of trouble speaking and right-sided weakness, that's always concerning. Non-dominant hemisphere stroke, for most people this would be a right brain stroke. and that results in weakness on the left side of the body, left-sided sensory loss, and rightward gaze. These patients will also have neglect, which means that they are inattentive to things happening on their left side. When that's profound, they may have like alien hand syndrome where they don't understand that that's actually their own body. And when it's mild, they just may attend less to visual or sensory stimuli on that side. Interestingly, because of the component of neglect, some of these patients may not be aware that they are weak. This is really important because if they don't recognize that they're weak or have vision loss, they are not reliable for telling you when it started. So it's just good to identify that because you'll need to look for collateral information to support the time of onset. So the pattern with right brain stroke is neglect and left-sided weakness. Those are the anterior circulation stroke patterns, and we also have posterior circulation. So cerebellar strokes are very tricky to identify because they're a little bit nonspecific. Patients will generally have what we call an acute vestibular syndrome, and that means they have a spinning sensation and nausea. But of course, we know that there's many things that can cause that, from GI illnesses to inner ear problems, so that can be tricky. They may also have incoordination or ataxia and gait problems, which can help you. This is just a picture of the cerebellum, or the back of the brain, with a stroke on the left side here. Missing a stroke like this in a younger patient can be really dangerous because they can have swelling in this area that can be life-threatening. So it's important to consider that, even for patients that maybe look like they have a stomach bug or something like that. And then finally, brainstem stroke. The brainstem is an extremely important structure that controls all your cranial nerves, as well as consciousness, and the motor and sensory tracts to your body. So stroke there can be very debilitating and devastating, and may present with unusual eye movements, weakness or sensory changes, and especially a change in consciousness. Other strokes generally don't result in you being less awake or less alert, so that's always concerning. These are the ones that are also may have cross signs, where you have weakness on one side of the face and the opposite side of the body. This picture is another head CT, and what it's showing you is this blood vessel here, the basilar, is looking really, really bright because there is a clot in it. So in terms of things that look like stroke but are not, many people present with concerning symptoms for stroke and end up not having a stroke. Probably the most common group is people that have a history of a prior brain injury, often a stroke, that had a lot of recovery and are now sick. So people that recovered from their prior stroke, they never, regrow brain cells, so they always have that scar. And when their overall systemic health is worse, they may see those signs of stroke again. So we see that a ton. So people that tell you this is just like my last stroke is actually usually reassuring because it's less likely to be a new stroke, and we need to think about them being sick for some other reason. When we see people with confusion, oftentimes that's delirium or an encephalopathy that could be related to systemic illness, medications, or baseline dementia, for example. And then things like hypoglycemia can cause focal deficits as well. Seizure is a common cause of stroke mimics. It can cause Todd's paralysis, which can be focal weakness after a motor seizure. Tumors can cause focal deficits as well. And then things like migraine can look very similar to stroke in some patients. And finally, people with stress reaction or mood disorder-related symptoms can have a stroke-like appearance. So for our first case, this is a 54-year-old gentleman that's coming in with dizziness and nausea. So his family called EMS because he could barely stand and he was vomiting. And so you can just play along with me since no one's here to call on, but what would you think to do next, right? So it's kind of a non-specific presentation. So first things, of course, that you always do is make sure that his airways, breathing, circulation is fine. And then if you're thinking about stroke, a stroke screening exam is the next thing. And I imagine that not everyone is using the same one, so I have a couple of them here. The Cincinnati scale is the first one, and just to briefly review this, it only has a few components, so facial droop, arm drift, and abnormal speech. Our patient has none of those, right? So he would be negative on that scale. There's another scale that the UW likes us to encourage to use, which is called BFAST, as you see here. And so this one has balance or walking problems or coordination issues. Eyes is the next one, so that's any kind of loss of vision or double vision. Face is looking at either numbness or weakness. Arms is weakness or numbness. Speech is either slurring or aphasia. And then, of course, the T is for time, which means that don't waste it. And so this gentleman does score on this particular scale for his coordination issues. And also you find he has numbness in his left arm that he wasn't initially complaining of, but you find when you're testing for it. So that's a positive scale. And then I know you may also use the FAST-CT scale, which is similar, doesn't have the balance, instead has neglect. So as you can see, the various scales that you use may help you pick up some more patients. It's important to note that, for example, this scale, it misses less stroke patients, but it also is less specific then, so it picks up more people that don't have a stroke, as you can imagine, by including things like the vertigo. So our gentleman, once you've determined that you have some concern for stroke, you need blood pressures, blood glucose, and really important to try to get the information about the last known well. We really depend on that information at the hospital, and often the family members can't be with the patient right away. Many of these patients are unable to give us information on their own, so any information you can get about the last known well is really important. Patients cannot be treated for stroke without this information. And of course, if the patient needs help with the history or with consent, if you can get information for the family for contact, that's fantastic as well. So we find that this gentleman developed the dizziness actually yesterday at 7. And he's been getting worse. Just before they called the EMS, he started having this numbness on the left side that you picked up on your exam, as well as ringing in his left ear. Now it's 2 a.m., and so I had a question on here, should we do a pre-hospital notification? And the answer is yes, as you probably guessed. So he scored positively on a stroke scale and has some focal symptoms in terms of numbness. So you would want to rapidly transport him and notify the hospital that you have a potential stroke coming in. So for our ED and most EDs, if you do that, when you get there, you should be going right to the CT scanner, and the things you want to hand off is the patient's information, what symptoms were concerning for stroke, last known well, and how you figured it out, and then any history you know about and any contact information you've picked up. So the reason that we want to have all this information is so we can know if they are going to be able to get any treatments for stroke. So just to briefly review those, the first treatment we consider is alteplase. So that's tissue plasminogen activator, or TPA. Tend to be calling it alteplase recently because there are some other players in the field of TPAs, as we'll talk about later. And so the intention of this medicine is to help thrombolyze the clot that's causing the ischemic stroke. You can only administer this medicine within 3 to 4.5 hours of last known well in most situations. So that's why it's important to determine if the patient is within that window. And then it's limited in that, given the risk of bleeding complications, you can't give it to anybody that may be at high risk for bleeding. So that's people that have a history of intracranial bleeding, tumors, recent trauma or surgery, or are on a blood thinner. And the majority of patients, even if they could be a candidate, are not treated because they don't come in time. So this picture, I'm going to show pictures like this several times throughout the talk. The way we look at data for stroke studies is actually really straightforward. It's based on their functional outcomes. And so these scale of 0 to 1 means that the patient at the end of being treated for their stroke either had no symptoms or mild symptoms. And then, of course, death is at the end. 2 and 3 is symptoms that interfere with some of their previous activities. And 4 and 5 are, requiring assistance, so not being independent. And the treatment with alteplase enhances the number of people that are mildly symptomatic after stroke and decreases the amount of people that die. Before you can get alteplase, you have to have a stat head CT, so that's why everybody's always going straight to the scanner if they can. We always check the blood glucose to make sure it's not a mimic and make sure that we know about their medical history so we know there's no contraindications. So our gentleman here went to the scanner, and looking at his head CT, we don't see anything concerning for bleeding or hemorrhage. That would be bright, like the skull is bright there, and there's nothing, so that's good news. I have another picture of the head because the radiologist at the initial ED thought that this area might be a little low density, which could be concerning for stroke. So that's very borderline finding, but just so that we're aware of that. So because he became dizzy last night, he's not a candidate for alteplase, even though today is when his numbness and his ringing started. So it's just important in terms of the timing. It can be a little complicated. It's the start of the first symptoms associated with a concern for stroke, and you would only reset the time if they had a complete resolution of symptoms in between. So otherwise, he wouldn't really be a candidate for alteplase based on the timing. So the other treatment we can offer is for large vessel occlusion, or LVO. So this is an acute occlusion of a major intracranial vessel, and about 25 to 40% of people with stroke have this. So most people don't have it in the first place to treat it. But if you have one, we have very successful treatments for that. This picture is just showing an angiogram, showing the anterior circulation, so the carotid artery, coming up into the M1 and all the branches, and the anterior cerebral artery. And generally, when we're talking about taking clots out of these arteries, the data is really compelling for carotid and M1 occlusions. We can definitely do M2s, and people benefit from that. And then smaller than that, it's kind of difficult to have anything get into those vessels in terms of thrombectomy. And just to review what the blood vessels might look like with the clinical syndromes you see, when we're talking about that dominant hemisphere stroke, where they have language dysfunction and right-sided weakness, here's the carotid artery coming up. Here is the middle cerebral artery on the left, and it just ends abruptly like that. Arteries should kind of taper gradually down smaller like the rest, and so that's the occlusion right there. For the dominant hemisphere stroke, non-dominant hemisphere, with neglect and left-sided weakness, we have the same kind of look where here's the middle cerebral artery should be, but it ends abruptly and you have no blood flow in this half of the brain. Each of these images is a conventional angiogram, so the dye is only going into one carotid artery at a time, so that's why you don't see the other side. And then for the posterior circulation, you have two vertebral arteries that come up to form the basilar artery. And again, here we are not seeing any blood get passed around this level, which is where there's an occlusion. And so these patients are the ones that have the altered mental status and can be weak and have extraocular movement abnormalities. So just as a review of mechanical thrombectomy, what is happening there is you use a stent retriever. So these are what they look like. This is the occluded vessel, and you pass the stent retriever up and across the occlusion and then pull it out. And so the clot is captured in the little netting, and then the artery is open. So ideally, that's what happens when you do a thrombectomy. In terms of seeing how effective it is, it was initially tested within 6 hours of the last known well for patients. This is that same type of scale where on this end is patients that have no symptoms or mild symptoms, and this end is patients that are dead or heavily disabled. And you can see that treating with thrombectomy really expands the number of patients that have mild to no symptoms. The number needed to treat for this is between 2 and 6, which is like insanely effective for this kind of procedure. So it's more effective than treating in MI, with stenting or with cabbage by a significant amount. So it's a very effective medical intervention. And then they looked at up to 24 hours after the first presentation. And this is a number of these graphs, but you can see that it's similar. This is now the therapy arm and the medical therapy. So the thrombectomy really expands the number of people that have mild symptoms and also reduces the number of people who die. And interestingly, the number needed to treat is very similar. So we use some other criteria on imaging to select patients in this extended window. And that imaging criteria is very effective for selecting patients that are going to benefit. One thing that's interesting to know about this is not every emergency department has the capability of doing that imaging, and that is a CT or MR perfusion that allows us to do that. So for our gentleman that had the dizziness and the left-sided numbness, he got a CTA, and what we can see here is this blood vessel kind of doesn't connect with that blood vessel. There's a clot right there. So that's in the basilar artery that we were looking at before. And this is just a front view of the same. So the artery comes up and then there's nothing there. We did do perfusion for this patient. And so what this is looking at how blood is traveling into the brain. And what shows up on this side in green is areas where the blood flow is slow because there's a blockage. And so it's showing us the back of the brain since this is a posterior circulation clot. On this side, it shows us brain that has already died of the loss of blood. And so we don't see anything there, which is great. So this is the kind of patient that we want to take the clot out where they have brain at risk of dying from loss of blood, loss of oxygen, but has not yet died. So that means that on imaging, he has a mismatch or a penumbra. Is the other way to say that. So these patients then go to our OR where we have a brand new fancy OR where we can do some of these procedures. So that's some pictures from that. And they undergo the thrombectomy we talked about. So this patient had a pre-procedure picture where you can see the artery ending. And post-procedure, you can now see it comes up and is giving blood to the back part of the brain through the posterior cerebral arteries. So it was very successful. It's kind of interesting to see it in real life, I guess, or as it happens. So I have these videos. I'll go through them a couple times. So this is just slowing, is real time as they push the contrast. And you can see how slow the blood is moving and that it doesn't move past the occlusion. And then after they've been treated, the blood fills so quickly, and you can see it fills all of the arterial section and then moves into the veins. So just an idea for what's happening during the stroke in terms of all of the neurons downstream here are not getting any oxygenated blood during that time period. So just trying to convince it that we can go to the next page. And I had one further apart video that shows the catheter all the way up. So they either go through the groin or the arm. And so you can see the catheter here snaking through the vertebral artery all the way up to the basilar. And you can see where in the skull it is. And that's what they use to get up to the clot and bring it out. Oops, sorry. So this gentleman did extremely well. He did not have any residual stroke symptoms. So that means that, when you did an exam, you couldn't see anything wrong with him. His MRI, this is showing the back of the brain or the cerebellum, shows some tiny amount of stroke there. Most people will recover very well from a small amount of cerebellar stroke. Interestingly, when we looked to find the cause of his stroke, he was found to have a heart clot, and that needed to be treated with a blood thinner to prevent further stroke or other embolic events. And he went home from the hospital, which is great. And I just wanted to point out that the natural history of these basilar occlusions is terrible. So prior to being able to treat them, they had a 60 to 90% mortality, and like 100% of people were severely disabled. This picture is not showing medical therapy versus thrombectomy because nobody would not try to treat them in these situations, but just showing when they succeeded at thrombectomy versus not succeeding. You can see that that's helpful. For some reason, this scale is backwards from the previous one, but this is the side that is worse if they just made it lighter colors to confuse everyone. Yes, please. Yeah, that's a great question. So there's actually not very many. Bleeding in the territory is actually not a contraindication. So as long as it's not a hemorrhage on its own that's life-threatening, it's not necessarily contraindication. And then the other types of things that are contraindications for alteplase, like the medications you're on, that's not a problem. We can definitely do it on antiplatelets, on anticoagulation. That's not a concern. And so The only big contraindications are things that have to do with their access through the blood vessels. So I recently had a woman with a very extensive aortic dissection, and looking at that, they didn't feel confident they could find the true lumen and not injure something trying to get up the vessel. So that's one reason. And that can sometimes happen in people if they have like a full carotid occlusion and then also a clot in the head. There may be no way to access the artery. So that's one thing. And then really the only other thing is some of the surgeons that do it are not eager to do it in people that have a short lifespan. So sometimes it'll come up if the person has metastatic cancer, for example. It's not really a contraindication to the procedure, but they may feel uncomfortable submitting people to a procedure in that context. That's a great question too. So there's it depends on the cause of stroke. And so everybody that's had a stroke has a higher risk of stroke in the future than if they hadn't. And initially, right after a TIA or a stroke, your risk is the highest it's going to be, and then it falls off over time. So some people right after a stroke will have another stroke. And most of the time, it's the same cause, but not always. And so we do find some people have multiple reasons to have a stroke. In terms of a picture like this, where he has this clot sitting in the artery, and the clot was from the heart, you can imagine he's at risk of throwing another clot from his heart, even if we put him on a blood thinner. But we wouldn't expect it to go to that same blood vessel again, right? Ideally, and really the vast majority of the time, with a clot that's thrown to the blood vessel, the thrombectomy doesn't hurt the blood vessel at all, and we don't usually have any follow-up problems with that particular blood vessel. However, there are many people that have disease of the blood vessel specifically, so they may have atherosclerosis or plaque disease in the blood vessel. And if that then clots off, you can do thrombectomy there. It's a little more tricky when the blood vessel itself is diseased, and those are more likely to then clot off again or need a stent put in them. So in that context, then they may have a recurrent problem in the exact same blood vessel. But the majority of people, if treated with thrombectomy, are not going to have a problem with that particular blood vessel in the future. So all I was saying here is we had this great outcome for this patient, but basilar occlusions historically had terrible outcomes, like really miserable outcomes where everybody was disabled because of how important the brainstem is to your overall function. And I wanted to point out they're pretty unusual for strokes. They often present with progressive symptoms, which is rare otherwise in stroke. And so like this gentleman, he had dizziness, and then he had numbness and this tinnitus. And, if he had not been treated, may have progressed to more severe symptoms. And one of the things that points out how difficult these types of strokes are to recognize is that if you look at how long it takes them to get to an emergency department after having their first symptoms, it's 8 hours on average, while it's only 1 hour on average for a left MCA stroke or a big left-sided or dominant hemisphere stroke. And it's exactly around the same amount of time for them to get a real diagnosis, so people don't think of it right off the top of their heads. And actually, I fudged a little bit of details with this case because he was actually seen in an ED right away. So he came in with the dizziness, had that head CT just 30 minutes after the dizziness started. But all he had was dizziness, and so they didn't think about stroke as a cause. I didn't think about alteplase, and that's, it's understandable, right? A lot of people are dizzy. So they planned to discharge him home. And then he developed that left-sided numbness, and they had that concern about the head CT. So they sent him for a CTA now many hours later, too late for alteplase, and found that clot. Then they called us, and unfortunately he was almost in the UP. So it took a long time for him to transfer down to us, at which time we were still able to treat him, which is great. But most of the time people present with these posterior circulation strokes. It's kind of a story like that, where all these medical providers saw them and didn't kind of pick up on it until later. And so especially it can happen that if somebody doesn't get the idea it's stroke early on, it's hard to then think of it. So you kind of get like an anchoring bias. And so as the first medical provider seeing a patient, it's sometimes helpful if it passed your mind that it was stroke, because it can kind of help send them down the right pathway, if that makes sense. And so I've seen many patients like this that got sent home, and then come back with, devastating, untreatable stroke. Or in his case, with this heart thrombus, he could have had ischemic bowel, ischemic limbs, all kinds of problems. So these kind of cases are really tricky. And it's always good to be thinking about stroke. So these are just the little summary points. Vertigo and nausea are hard because so many things cause them. But if there's anything else focal, like the numbness on one side or the hearing change on one side or double vision, slurred speech, then start thinking about stroke. Alteplase generally only can use it in the 4.5-hour window. So that's why it's important that we are identifying things quickly. But then thrombectomy up to 24 hours and sometimes even longer in current patients. So our next case, this was a younger woman, 38, who's presenting with confusion. So she's with her family, and they were with her. She suddenly wasn't talking right. So that's why they called. And when EMS arrived initially, she was awake. She was paying attention, but she wasn't talking at all, not saying anything. And her family is telling the EMS there it started just 30 minutes ago. So our initial thought is that's a stroke symptom. Of course, we're going to use one of these scales, whichever one, and they all include abnormal speech. So she'd have a positive stroke scale, despite her young age and no other symptoms. Just want everybody to think, what do they think this is? What could it be? And what would you do next? I'm kind of hoping that you'd think it's concerning for stroke. I'd notify and bring them in as a stroke code. So in the ambulance, unfortunately, she starts to decline. She starts to vomit uncontrollably. Her blood pressure is very high. And what I want you to be thinking is her airway protected? This woman's actually aspirating and did need to be intubated. And I want you to think, now that this has happened and she's worse, is it changing my idea of what's going on with her or what her problem is? And then you'll see that you were right, of course, because what with the high blood pressure and the decline in her symptoms, you're worried about a hemorrhage. So intracranial hemorrhages are a minority of stroke cases, but they're very dangerous. And one of the reasons is because the people will have neurological decline. And so this woman, as you see, has this big area of blood in her left insula and frontal lobe, which is why she wasn't able to talk. She had aphasia. And she's continuing to bleed, which is why she was getting worse as you're trying to get her to the hospital. The other things you can see on this CT, if you remember looking at the CTs of the other patients, is that we could see some fluid spaces in the brain, which she doesn't have because the bleeding is causing mass effect. So of course that's dangerous for patients. If it gets too severe, it can lead to death through brain herniation. And this is a kind of a front-wise view just showing the hemorrhage. Just a cool thing you can see on imaging that was present in this woman is you can see the ongoing bleeding. So it's called a spot sign. So on your non-contrast CT, you see the blood. If you do a CTA, you may see that she's getting some contrasted blood. And then if you do a little delay with the contrast, you can see it getting into the hematoma. So the problem with an intraparenchymal hemorrhage is that it's still bleeding, which can cause the patient to decline and have worse deficits. And so we can actually see when they're actively bleeding on their initial imaging in hospitals that have the capability to do CTA. So just briefly, little summary about this. They have very high mortality, up to 60%. And they're at high risk of deteriorating clinically. So this little graph's a little blurry, I'm sorry, but it shows them accumulating neurological problems after their initial presentation, and it can be quite early. They're less than 15% of strokes, but they have a larger burden of death and disability because they tend to be more serious for these reasons. So the way we treat these patients is medical treatment is focused on treating the blood pressure and reversing any anticoagulation because the goal is to keep them from having more blood in their head by reducing the hematoma expansion. They can also have surgical treatment. So that's either an open cranie to evacuate the hemorrhage, or they can do catheter-based evacuations. And I thought this was cool and didn't know if people had seen this before. So I snagged these slides from one of my colleagues, Dr. Ahmed in neurosurgery. So we ran a trial here at UW for one of these procedures. And instead of having a whole big section of your bone removed, they can do just a small hole with a burr hole and then use a cannula into the hematoma to extract the blood. And so he's showing you how small an incision it is, and this is the cannula. And this is this patient, so you can see how much less blood she has in her head after undergoing this procedure to remove the blood. This woman, she needed some therapy, but she was able to go to rehab and is on her way to recovering. So I just wanted to show you a case of a hemorrhage, because while they're the minority of stroke presentations, they're dangerous in that they progress, and certainly can in the time period that they're with you, which is why all patients with stroke need to be frequently reevaluated in terms of their vitals and their neurological exam. This woman needed to be intubated, right? And that can happen because with hemorrhage, they will have decreasing mental status and may become comatose. And then, as well as ischemic strokes, hemorrhages also benefit from rapid transport and management. So that's that one. And then for the third case, I think I put on the intro that this is the bread and butter case, but I wanted one that was like a normal stroke case, so you don't get just all these kind of weird or unusual ones. So we can go through this one kind of quickly. But this is a 65-year-old woman with left-sided weakness. Her husband saw her in the morning when they woke up and then found her on the floor. The important point about this is when you're getting information at the site, knowing the time that she was found on the floor doesn't do anybody any good for anything, right? Like, that's because we need to know when she was previously okay. And sometimes that's hard to remember and people don't know to tell you it, right? So you have to remember to ask for that. And then, unfortunately, this woman has atrial fibrillation, but had decided herself to stop her medicines last month. On her exam, she has left facial weakness, left neglect, and left upper and lower extremity weakness. So she's going to be positive on all these stroke scales and the EB FAST as well, which I believe is one of the only ones that includes neglect. So, of course, you're going to notify whatever hospital you're bringing her to. She went right to the scanner, and her scan looks fine. There's no bleeding. And an interesting finding she had on hers is you can see the blood vessels here. So this is going to be the MCA. And it's really bright in this section. That's the clot. So it's a hyperdense vessel showing the clot that's causing her stroke. As you see, the time is EMS got her right in. It hasn't even been an hour and a half since her symptoms started. So after the scan, she was treated with alteplase. So we also do a CTA. This is a video just because a single picture, it was hard to see the occlusion because of the way it was done at this hospital. So I'll go through it a couple times, but first time you might look at the left side, and I'm going to go through it again. But if you look at the left vessel, you have to kind of scroll up and down, but you can see that it goes all the way out to here. Now, if you look at the right vessel, if you follow it, it doesn't go anywhere. It just ends. So on any particular slice, it's hard to pick that up. But she has an occlusion in essentially the same place we saw the hyperdense vessel. Alteplase is less successful at treating large vessel occlusions than small vessel occlusions, as you can probably imagine. And the bigger the clot, the less likely it is to recanalize with just alteplase. But an important thing to note is that in all of the trials for thrombectomy, all the patients that were candidates for alteplase did receive it. So it's still the standard of care, even if you plan to treat the patient with thrombectomy. So she was treated with thrombectomy, and there was only one picture that they took before removing the clot, and you can see the blood vessel ends right here. And then now you have the catheter, and the clot is gone, and all these blood vessels filling. And I have a video of that too, I believe. They didn't have the video of the pre, because they just grabbed the clot out right away. So just show that again. So catheter, and then all the blood vessels filling. So she also did great. She had a normal exam as well and was able to go home. This is her MRI, and you can see these just scattered little bits of stroke. If she had been untreated, likely everything from here to here would have been ischemic stroke. So a typical patient that has an M1 occlusion like that, you know, they would not be walking independently. They might need a peg tube. They would definitely not be independent. So it's an incredible difference for these patients. And we did start her back on her blood thinner, so hopefully she'll be at lower risk for stroke in the future because she had that atrial fibrillation as a risk factor. So I wanted to talk then about a few things that are new-ish. And so they're not brand new, but they haven't quite come into our medical system yet, so you can be ahead of them. So one of those things is tenecteplase. So tenecteplase is a tissue plasminogen activator like alteplase, but it was designed to have more selective binding, and it has a longer half-life. So they hope that it will have less bleeding complications. And the thing that's interesting to EMS a lot of the time is that it's a single bolus. So none of that 1 hour infusion, which would mean that when you're transferring people between a small hospital and a comprehensive center, you wouldn't need to worry about managing that or being equipped to have a pump or managing a pump. And it's also less expensive and may not need to be refrigerated in the same way. So places where they have things like stroke, mobile units could maybe have it on board easier. So there are several studies showing that it's non-inferior at least, and I have another of these graphs set up in that same way. And it has alteplase on the top and tenecteplase on the bottom. And overall, the trend is certainly towards being superior. Some of the things about it is that it has only been tested in patients with an LVO. And so like we talked about, that's a minority of patients. So it hasn't been tested extensively across all the types of stroke patients that we treat. And it's not yet FDA approved. However, many hospital systems have switched entirely to using tenecteplase or TNK instead of alteplase for the cost and efficiency reasons. And so we've already been talking about it here and decided not to do that, but big hospital systems have decided to do this in parts of the US, and so you may run into it, certainly in the future, and even now, just depending on where you are in the region. So that's important to be aware of. And then wake-up stroke, I get a lot of questions about that. So these are patients that the last known well we would generally consider to be before they had gone to sleep, and now they're waking up more than 4.5 hours later with stroke symptoms. And it's always been unclear when the stroke happens during sleep, but people suspected that it was not early in the night, more close to the time that they wake up. And so is it possible that we would find an indicator that would let us know which of these patients have suffered irretrievable brain injury and don't need to get alteplase versus ones that maybe have a penumbra still, as we see on our CT perfusion, and would benefit? And so there's been a number of studies where they take these patients, and they usually would say 4.5 to 9 hours, or like from the midpoint of sleep, and do some advanced imaging to see if they might be candidates for alteplase. And so in the studies we have so far, they needed MRI, and they were looking at MRI to see if there's a distinction between brand new stroke that you see on a diffusion weighted image and stroke that's slightly older that you see on a FLAIR image. And if you had this kind of mismatch, then you would potentially be a candidate for alteplase treatment in this extended window up to 9 hours. So these studies all did show benefit, and so I'm showing you these pictures, and this is why you hear about this now, is that giving alteplase to these patients improved the outcomes of a number of people. And one of the concerns is it also increased the number of people who died, of course, and increased the number of people who bleed. So that's always a bit concerning because it's more of an ethical issue to weigh that kind of question. Also, the studies were limited because some of them were stopped early. And also, this was happening just as we were understanding how much people benefit from treatment of LVOs with thrombectomy. So they include people that nowadays would get a thrombectomy, if that makes sense. So it's not exactly the patient population you'd be thinking of applying it to now. However, it's certainly something that people will do in certain situations where they think it's appropriate. And so you can treat some stroke patients with alteplase in a late time period, up to 9 hours. And to do that, you'd need to get them to a facility that had an MRI and a neurologist, because certainly it's kind of a complex decision. So we've been getting a lot of questions about this when we're talking about triaging patients from other EDs. So just thought it was worth mentioning. And then briefly, just talking about access to stroke care. As you're all aware, we're all in a hurry because these are all very time-sensitive treatments, and you're losing tons of neurons every minute that you delay when you're having an acute stroke. All of the outcomes for everything are the best early, and the later you're doing treatment, especially with alteplase, you're increasing the risk of hemorrhage. And this graph is just showing the benefit falling off over time, and that's how they decided the original kind of time window. So in terms of what's available where, any hospital in Wisconsin should be able to administer alteplase. All they need is a CT scanner to do that. And so that's why, especially if you're very far away from a comprehensive center, that's why the closest hospital is usually reasonable. We as neurologists, especially with UW Stroke, assist doctors throughout the state and EDs with making this decision, if it's a complicated decision or if they just want assistance. And we do both telestroke with some sites, but we also take phone calls from everywhere. And then those patients may require transfer to hospital with ICU level monitoring or other capabilities, which is where you may meet a lot of these patients as well, being transferred from one site to another. And then thrombectomy is only regularly available at the University Hospital and a few other places in the state. Some other hospitals have it available occasionally because they'll have like one provider that does it. Generally, the pattern in a more rural state like ours is that you receive alteplase, the closest place to you, and then transfer via the fastest route to our center if you have an LVO or a high suspicion for an LVO. And then there's some of these stroke scales are being used to predict the likelihood of an LVO too. So we don't have one regionally that we've all agreed we should be using for triage, but that's something that would be useful in the future. It's an older map, but it just gives you a feel for what is available around the area. And so in green, it has the comprehensive stroke centers where we can do thrombectomy. And then other stroke centers, where they're capable of treating stroke patients are in red. And then, other hospitals, essentially everywhere, should be able to give alteplase are in blue. And so you get a feel for most of the state is in a situation where they need to go to the closest hospital and then transfer to a comprehensive center. In town, like in Madison or Milwaukee, there may be a rule for a regional agreement on going straight to comprehensive centers when you have a stroke patient. So that's what I said here. And again, so people ask this a lot. And if you're, here in town and you have someone that looks very sick from something that looks like a stroke, then you're probably going to save time by coming to the university hospital. But there is not, although there should be, an agreement between all of our medical systems here on a bypass plan. So that's something that still needs to be developed. And so just to kind of summarize, stroke is a really common disease. It causes an enormous amount of disability, and we can treat that disability and prevent it essentially right away if we recognize it very quickly. And so all of the treatments, some of them are the most effective treatments in medicine practically, but are really time sensitive. And so we have to get the patients to where we can offer these things. And patients that are recognized by EMS, of course, they're going to get faster into the kind of stream of stroke workup. So we really depend on EMS to recognize that they have a stroke. And the other side is getting the information that allows us to treat them, right? So a lot of these patients can't tell us anything, and if we don't have either their family's contact information or the report, it really ties our hands in terms of what we can do for them. So think about stroke, including those kind of rarer cases that we talked about, and use whatever stroke scales you're using in your region. Get the last known well if you can, and make sure to always question it if it's a time of it was noticed, unless the patient is telling you that. Likewise, if the patient is not reliable because they don't notice their own stroke symptoms, or because they have underlying dementia or what have you, you need to look for collateral information. And then if you know you have a stroke, you want to do pre-hospital notification if you can, so that everybody will be ready to get them imaging and treated as fast as possible. Believe that's all I have. So I just wanted to say thank you, and I'll take any questions. Yeah, the BFAST scale, sorry if I have to go through there. It's one of the ones that is leaning towards as many things as you can notice, if you will, is less specific. So any type of abnormality of the extraocular movements you can include. Does that make sense? And then of course the problem with using a scale like this that's more all-inclusive is it's going to get you more non-strokes identifying as positive, but you'll miss less true strokes. So.
Okay, thank you.
So I would say the problem with all of these patients when they're with you is that we don't know if they have a hemorrhage or not a hemorrhage, right, yet. And that it's a huge dichotomy in how we manage their blood pressures. So it's tricky. And to treat everybody, you would want to minimize big changes in blood pressure till we know, right? Because ischemic stroke patients need their blood pressure to keep from infarcting more. And then, of course, hemorrhagic stroke patients, we need to treat their blood pressures. If they're outrageously high, then you can feel comfortable lowering them. But almost nobody benefits from like really, really drastic and sudden changes. And so that is one aspect of intubating people, which is many of the pre-treatments may affect their blood pressure. So mostly we would avoid drastically tanking a blood pressure, even if it's high, if that makes sense. And then in terms of intracranial pressure, this, I think, would be an issue mostly in people that are comatose, because in other people, it's unlikely to be so significantly sized a hemorrhage. So I don't know if you would need the pre-treatment as much. Does that make sense? So people that are going to have a big enough intracranial mass that a change in the intracranial pressure related to a medication would be serious, probably are not going to be hard to intubate, is what I'm getting at, because they won't have much in terms of their exam and have low Glasgow Coma Scale. And people that are going to need pre-treatment, probably it's not going to hurt them. Does that make sense? Yeah.